Okay, I think we can just start. People may still be coming in, but since it's only me talking first, it's fine if they miss the start. Welcome to this session on research. My name is Johan Sabbe. I'm an associate professor here at the University of Oslo. And I don't have much of my own research to present today, but I'll introduce the kind of research track that we had for the annual conference this year. I'll say a little bit about the background, starting last year in this very room, leading to 4 sessions on research or featuring research this year, together with also call for papers for a special issue in a health journal related to research on DHIS2. In between there, I'll also say a bit about us as a group, since I now realize that many of visitors from far and wide may not know the kind of research we do here also in Oslo at the HISP Centre and the University of Oslo. So last year we talked about research. Should we expand the room to discuss research also at the annual conference? And I think there was agreement that that would be good. Many are holding dual roles. They work at ministries, they implement, they use DHIS2, they also do research. And many of us are, engaged in research, even though that's not our primary role. So building on that, we had a few webinars on research. We discussed having a research track at this year's STAC, which we have now. And also very happy, together with Karen Greppin here, to have worked on a special issue in SSM health systems. I'll get back to that. So this is just a background. We have been talking with some of you for the last year. And this has led then to, we had 30 abstracts submitted featuring research, and 8 of them will be presented today, together with also a lot of posters. So do take the opportunity to visit the posters. Just a quick introduction of us. All of you know HISP and DHIS2, and an important foundation of HISP has been action research, meaning that the practical work of solving problems goes together with research. That is how we as researchers acquire knowledge. And that is also how we learn new ways of solving the problems. So this kind of reciprocal relationship between doing things and reflecting on and disseminating research. So this is the modus operandi of our group. The Information Systems Group is the name of the group within the HISP Centre that does research and also teaching. We are around 9 staff. There are some seconded professors on part-time. There are some professors that are slowly going into retirement, etc. Currently around 25 PhDs in our group. I don't know the numbers, must have been 30, 40 that have graduated PhDs or more, 60 PhDs. Some of them are here in the room and at this conference. We have 3 areas of research that we do here in Oslo. The broad topic is information systems. So many of you are doing research on health, etc. Our interest is typically interplay between organizations and technology. That's what information system typically deals with. How does the evolution of technology influence and how is that also influenced by organizations using them? Part of this is linked to the field of ICT4D. So are we making a better world with IT? We're not just interested in context where the primary motivation is to look at organization efficiency, profits, etc. We are interested in making a better world with IT. And we do this by focusing on health or other public services, education, agriculture, etc. So that is what we do. Very short example here of research we do. This is actually research on the development of DHIS2 itself. Basically looking at our dilemma as platform lead, developing or coordinating the development of DHIS2. We want different users, different contributors of DHIS2 to have as much freedom as possible to create social value. But we also recognize that in that process, so much good is created, so much innovation and knowledge is created that would help others to create even more social good and social value. So we have this dilemma between giving freedom to as much as possible and making sure that whatever is created in that process is freely available for others and not privatized, which we typically see in a lot of other digital platforms. So we are doing research on such issues. How can we govern the development of a global platform like DHIS2 so that it maximizes the potential for social value, acknowledging that this potential for social value is created through innovations in countries. Another example of maybe an idea for future research or coming up now, how can we support the research infrastructure building on HISP? We have no idea, we have some ideas of what it could be, but no idea what it should be. We see that there's a great demand for health data, for research, policy making. We see that there's a lot of health data available, and we hear that there's challenges, as always, in getting access to good quality data in a fair and transparent manner. We've heard these stories about exploitative research, extracting data, and taking all the benefits of using that data for research. Is there a possibility to use the HISP network to do something different? Can we think of kind of a transaction platform for connecting parties, data controllers, experts, various fields, etc., to be able to collaborate on research in fair and transparent, equal manner? Yeah, so this is kind of research that we would be interested in. Now, moving over to the research track, the research you have submitted in your abstracts. We have 4 sessions, 3 today and 1 tomorrow. The 3 sessions today, we have 3 speakers each. So this is the first one, and as soon as I'm done, I'll give the floor to Flavia here from Makerere University, Implementation Research for Digital Registries. We have also Carlos Tejo Alonso from Solid Lines Tech Services, presenting on digitizing DHIS2 data using voice, images, and AI. That's in this room now. After the break, we continue with the research track in this room. We have 3 presentations then. Karen here on the effect of COVID-19 lockdowns on fertility. We have Yoshito Kawakatsu. Are you here now? So I see you? No. Presenting on climate hazards on MNCH service delivery. And then Donat Chamba from Ifakara Health Institute presenting the impulse study on newborn and stillborn data, comparing or looking into data quality and availability in Central African Republic, Tanzania. It's going to be a long day. The last session is in the other building, the tall building here, Nils Henrik Abelshus. It's in the first floor, so it's not very far. Room 107. 3 presentations. Again, Karen Grappin on behalf of a group of authors deriving population estimates for DHIS2 data. I'm really looking forward to that. Population data has been an issue for the last 50 years. How do we know the population to calculate indicators, for instance? Mahima presenting on randomized controlled trials using DHIS2 tracker. And last, David Hotchkiss from Tulane University, leveraging DHIS2 data for impact evaluation in conflict affected and resource constrained areas, evidence from the DRC. So a full list of different topics, some using data from DHIS2, some doing research on the implementation of DHIS2, and some looking at more, the features of DHIS2. So I think the exciting aspect for me, at least, is that we do research on so many different areas around DHIS2. The session tomorrow is organized by Wilfred and Marina, looking at data use at subnational level. This is kind of a research infrastructure they have made in Tanzania, in a collaboration between the Ministry of Health, HISP Tanzania, University of Oslo, and University of Dar es Salaam. A couple of districts that function as an area to do research, action research, to try out interventions and evaluate them. So they'll present results from that tomorrow. Which leads us to the last point I want to bring up. There is, after the session program today, when that ends at 4 o'clock, there are these expert lounges out in the lobby like yesterday. Karen and I will be in one related to this call for papers. So, as I said, building on last year's discussions and recognizing the all kinds of different types of research we do, we have a very broad and open call for papers in the SSM Health Systems Journal. There will be more if we go to the call for papers. There will be more information there, but basically we are interested and we want to showcase the broad range of research, and we think there are synergies between these different types of research. We apply different methods, we have different units of analysis, and I think together this is going to be really exciting to see what different research groups gets out of this phenomena. Yeah, I'll skip this in interest of time. I think maybe the two most important points is that it's free. And the deadline is end of August. So the journal very kindly have waived all APCs, which is typically what journals charge for you to publish. And it's also open access. So no costs are associated with publishing, no cost associated with reading. And that's in the spirit of HISP. But you have to make it by August 31st. So any questions you have related to this special issue, please come and see me and Karen in the lobby at 4 o'clock. I'll be very tired then, but I'll be there ready to answer questions. If there are, yeah, we have a minute if there are any questions quick now. Or else we move into the proper research presentations. And then I'll ask Flavia to take the scene. Yes, I'll set it up for you. Or hear than me. Okay, I think you're all set to go, and you have total 20 minutes.
Okay. Good morning. Can you hear me? Okay. Good morning once again. My name is Flaviana Magembe from Makerere University School of Public Health. I'm currently a PhD student, but don't worry, I'm not going to present my entire PhD here. I'm going to talk about implementation research for digital registries, specifically a case in point in Uganda where we implemented an NC e-registry using the implementation research approach. This particular presentation is just part of a bigger project. This was a project that has been ongoing in Uganda, not only about implementing e-registries, but also to evaluate the quality of care for ANC. But what I'm going to talk about today is the process that we went through to implement the e-registry within primary healthcare facilities in Uganda. So just to give us a bit of context, Uganda is one of the countries which has a high fertility rate in East Africa. Approximately, as reading online, and it indicated that women in Uganda give birth to approximately 5 to 6 children. So that means many women get pregnant, and the more women get pregnant, the more demand for antenatal care services. And the more they come for antenatal care services, that means there is a lot of individual data that needs to be managed. So that implies that we need to devise means of how best we can be able to manage that individual data. So when you look at the hierarchy of primary healthcare facilities in Uganda, we have right from healthcare center 1, 2, 3, 4, general hospital, and the rest. But most of these women attend antenatal care from the lower level primary healthcare facilities. These are the health center 2s and the health center 3s, and up to 70% of them, that is where they do the booking visits, and maybe when time comes to give birth, they will go on to the higher level facilities. So how is this data managed at the lower level healthcare facilities? When you look through the next slide, it is purely paper-based. And most of us have talked about the challenges associated with paper-based data management procedures for managing data. And while we were interacting with the midwives who offer these services to the women, one of the issues that they kept on complaining about in the formative research was that there is a lot of registers. They spend a lot of time documenting in multiple registers. And I remember one of them vividly saying that they spent up to about 3 days compiling the end of month reports. And so the need to make sure that they deliver antenatal care services in the best way possible by digitizing the data at the point of care was clearly evident. And so this project and the entire group, Makerere University School of Public Health, HISP Uganda, we work together with the Norwegian Institute of Public Health to develop and implement a point of care electronic registry, which you can call a DHIS2 tracker for antenatal care, to ensure that the midwives can be able to capture the data at the point of care. And at the end of the day, they can be able to easily access that data, be able to share that data, and be able to easily see how their data is being populated out on the dashboard. So how did we start? First of all, according to the WHO provides a template which can be able to be used to come up with digitized electronic registers or digitized EMRs for antenatal care. So what we did in the beginning was to compare what the WHO template, which I'm going to call DAC, provides in terms of data elements. And in addition to that, it provides the workflows, decision support, a lot of details in that template. So we customized that digital adaptation kit for antenatal care to fit into the Ugandan context. And at the end of the day, we came up with a registry that provides those functionalities, right from capturing longitudinal data at the point of care, providing clinical decision support to the midwives as they're providing antenatal care to the mothers. And also it has a functionality of SMSs and providing appointment reminders to the mothers, and at the end of the day, being able to provide automated reports, which is one of the main functionalities of the electronic registry for antenatal care. So what does implementation science come in? Now, again, just to give more context for antenatal care, some of you who have been in these antenatal care clinics in lower level primary healthcare facilities, these are heavily populated facilities. They have so many women, and usually they are understaffed. And in addition to that, in my setting, when the midwives are providing antenatal care, it's not the only thing they provide. They will do immunization, they will do family planning, and sometimes they're also going to offer maternity services within the same area where antenatal care services are provided. So what does this mean? This kind of environment is complex. To introduce a point of care system where you expect a midwife to be able to be using a computer or a tablet or a mobile phone while she's palpating a woman, at the end of the day also documenting, it becomes quite complex. So the reason as to why we adopted the implementation science approach, which mainly looks at methods or strategies to ensure that interventions that we come up with can be able to be sustained and used routinely in our settings, came into play. So one of the things about the reasons that's why implementation research comes into play is because of the 17-year gap. I think we can be able to see this. Some of you have come across this. This was in 2000. I'm certain now that the gap has sort of reduced, because they're saying that in 2000, it took about 17 years to realize 14% of an evidence-based intervention. Now, I know in our countries also, as we've come up with so many interventions, and these interventions are evidence-based, they work. We know that digital health can actually improve service delivery. The healthcare workers can be able to easily access and share and be able to use their data. But how best are we implementing these particular interventions? And another question would be, are those interventions used the way they are supposed to be used? Are they routinized? Or in my setting, for example, most of the time when these digital health solutions are implemented, they are not used the way they are supposed to be used. If they're supposed to be used at a point of care, sometimes they will, other times they'll not do that because of the so many underlying factors in the particular context where we implement this particular intervention. So implementation implementation research emphasizes key things like understanding the concept, the context. Where is the intervention going to be implemented? Who are going to use the intervention? How are they going to use the intervention, and so on? And why are we doing that? To ensure that we understand how best to roll out this particular intervention. And in addition to that, we need to identify methods or strategies of how best to support the people that are going to be able to use this particular intervention. I usually explain this in an easier way. If you're a mother and you have a baby who is struggling to eat, there are so many dramatic things you're going to do to ensure that this baby can feed. You support them, you dance, you clap, you give them the colorful plates, you do all that, so many little things to support them to enjoy the meal you have prepared. This is the same idea. We have so many beautiful interventions. How do we support the people that we've developed these interventions for to be able to use them the best way they're supposed to be used, such that they can be able to benefit from them? So there are key concepts in implementation research, which we operationalized in while implementing the electronic registry. So I've talked about what the intervention is. What is it that you want to implement? And is there a need for that particular intervention? Or are we just implementing something just because for us we know that it works? If it works for you, it doesn't necessarily mean that the people that you're developing it for need it actually. And then in addition to that, implementation science rotates around those strategies, the activities, the methods that you're going to do to ensure that you roll out the intervention into the implementation context for it to be able to be routinely used. And at the end of the day, we need to measure how this intervention is working. How well is it working? How much of that intervention has actually been adopted into practice? And once we measure, we can be able to go back and see where we started from, what we did and how we are able to perform, such that at the end of the day, we can be able to know whether we are still on track or we're falling off the track, and we need to go back and redesign our strategies to ensure that the intervention is clearly being used. Now, implementation research has so many frameworks, and over 60. You can get lost in those frameworks, and I'm not going to talk more about them, but you need a framework, and that framework is going to guide you on how you're going to do the process of implementation. It is going to guide you on what determinants or what constructs are you going to look out for when you're trying to understand the concept, and then when you're developing strategies. What are you going to refer to? Because there's so many strategies that we come up with, but there is a standard way or a format in which we can be able to structure these strategies such that even other people who read about our work and they've done implementation research can be able to relate. That's one of the purposes of identifying a strategy. Why would you identify it? How would you identify it? There's so many, it depends on the objective of your work. If you want to study the context determinants, there are determinant frameworks. If you want to understand the process of doing implementation, there are frameworks which are designed for that. And then there are frameworks which can guide you also in doing a process evaluation, an outcome evaluation, and an effectiveness evaluation. So this is how we did implementation research while we're implementing the e-registry or the DHIS2 tracker for ANC within primary healthcare facilities in only one district in Uganda. So we began by identifying or assessing the context, trying to understand what exactly is happening within these primary healthcare facilities. Yes, there is a need, but what are their workflows? What data do they use? How is this data related, or what is different between what WHO recommends in the DAC and what they're currently using as their source documents? But most importantly, we did an infrastructure assessment. We also identified so many barriers from these particular recipients or the people that are going to use the system. They told us all the fears about using the electronic registry, but also they were positive enough to tell us that much as there are so many barriers to using this, we love it, and there's some things within our settings that can support that particular implementation. So assessment took a lot of time because we're working with 36 facilities at 2 levels, health center 2s and health center 3s, and they're slightly different in the way they operated. We needed to understand that such that we can decide on, okay, if we have a web version and an offline version, which of these facilities would work best if they're having an offline version or a web version, and what kind of other equipment would support them. And then 2, we were able to identify strategies. Some of these strategies were recommended by the recipients, because when we're doing data collection, we told them, okay, you've told us so many problems or so many fears. We know, and you've told us that you want this intervention. So how can we be able to introduce it in your setting? So they were able to give us all that, and then we structured it into the different strategies. And then we implemented and deployed using a co-design approach, not just giving it to them and not just taking it to them for testing. There is a confusion there where you think you're doing co-design by giving the intervention people to test, but we collaboratively worked with them, taking them actually mapping out what their workflows are, and then being able to show us what we need to change to fit into their context. And lastly, we are in the evaluation process. So this is how implementation research was rolled out. I'll explain more about this. So this is a model which was developed by Mitch et al. 2011, and it presents how you can be able to structure your barriers and strategies based on people's capabilities, the opportunities, and the motivation for them to use the intervention. So when we look at the capability, most of their fears were that they don't, most of the time, these interventions or these systems are complex. And the strategy there that we came up with is to collaboratively work with them. It was hectic, it was time consuming, but it paid off. Why? Because even before we took the intervention, every time we'd go to these facilities, they'll tell us, why aren't you bringing it? We are ready. Please bring it. Let us start. And so it gave us a sense that because they already knew and they've worked with us for a long time, they were actually the ones demanding for it than us giving it to them. And then I'll just go through this very briefly. For opportunity, we noticed that within some of these healthcare facilities, they're already using DHIS2, but at the aggregate level. But and also there were medical records officers whom we used as super users to champion the intervention. Then in motivation, what are those things that demotivated and motivated them? Demotivation, of course, the workload. That is clearly everywhere. As long as you're introducing a digital registry or any other AMR, they will say there is workload. But we're not going to lament about workload. We need to ensure or devise means of how best to overcome that barrier. So we did a gradual process, not bombarding them with entering everything, but it was a gradual approach beginning with first NCs, and naturally the usage took place. Briefly, I have only 1 minute. So what are our achievements? Our baby grew up. We are almost making a year. We implemented in July 2024, and we are almost celebrating our birthday, which is good. But how are we performing? Well, so right now it is being used within, it was implemented within 36 facilities. However, there are some facilities that have dropped off. That's among the challenges, which I could talk about later on. But we have so many clients that we have registered. Over 10,000 clients plus have been enrolled into the e-registry. We've been able to automate the reports, and the midwives or the health workers at the facilities, at the district, they can be able to see how the data is coming in. But it has not all been a rosy process. I don't want to lie to you about that. Implementation is it's a very bumpy road. And even as I'm here speaking, someone may be sending me a message that please come, the internet is off, we need to do this, refill the IDs. It is a lot. But at the end of the day, it is how we support these recipients to overcome those particular challenges. And for me, in conclusion, I've come to notice that barriers to implementation are going to happen everywhere. Before implementation, during implementation, and post-implementation. So that means at every point, you're trying to adapt your strategies to fit into the situation. Sometimes you don't know where you're going. And that's the beauty about implementation, is that you go into the implementation, you don't know what exactly is going to happen. But as things happen, you adapt your strategies to fit into the environment. Ladies and gentlemen, I beg to submit. Johan has told me I have 1 minute. Oh, actually, I'm done. So I will, do you have 1 minute for questions? Okay. Yeah. So, yes. Yeah. So we have plans to scale up, but we need to first do, I forgot to show the slide for the next steps. We will first of all need to do evaluation to understand where we were, where we are now, and how best we can be able to implement even in other facilities. So this is currently working within government-aided facilities in one district in Mukono, and that's only Health Center 2s and Health Center 3s. But this is also being extended to accommodate birth and death registration. And once all this works out, we can be able to expand even to Health Center 4s, general hospitals, and even maybe in other districts. So yes, there are plans to scale up. But for now, that's where we are. Yep. My other colleagues can also come in because this has been, yes, please.
Just for the question, if you can speak to the microphone so we can also hear it online.
Go back to the previous slide. Yeah. Ongoing challenge.
Yeah.
Ongoing challenges.
Again?
Challenges.
Oh, challenges. Yeah. Here.
Is there frameworks, solutions to overcome these challenges? Is there qualitative study with the stakeholders, patients, managers, and themes to how to solve these challenges? Thank you.
Thank you. So there's a lot that has been documented about barriers to implementing electronic or AMRs, especially in low LDCs. And most of the time, there's a lot that has been documented on the challenges. But how they overcame those challenges There's some documentation that has been done, but it is not so massive out there. And so that is why we want to ensure that we publish all this. Some of the things that we have used have worked. For example, we've used audit and feedback, some of the strategies, whereby we identify that this midwife is a champion. She can encourage others. And once they hear from her, we've had a scenario where others could not actually believe that one midwife can use a system within 5 minutes while she's working on a mother. So when a big group, and when she gave that feedback, they said, really, we are going to come to you and benchmark. So that worked. Sometimes you don't know whether it will work, but you try it out. And as you try it out, you sort of like, work upon it, or you adapt it to be able to meet or fit into that particular context. But sometimes there's no that this works, that this doesn't work. There's been what has been meant to work, but it may not work in your particular setting. My other colleagues maybe can come in and say something. Yeah. Yeah. Okay.
Okay, so I'll go with my question. Thank you so much. And I would like to appreciate the work. I know how implementation research could be challenging. I think that your response to this question touched upon what I wanted to bring out, because in the context you have highlighted a specific challenge, which is the balance healthcare workers are trying to make between providing the care and entering data. This is a conflict that is permanent when you're implementing digital technology in healthcare settings. And I think we could better highlight how we overcame this divide between this conflict between I want to save my time to take care of the women and I need to enter data. And I think that the communication could better emphasize on how this divide is overcome, because this is the number one challenge that you have when you're implementing electronic registries and similar technology.
Yeah.
Over.
Thank you very much. Thank you.
Hello, my name is Eric Minyambabazi. I work with HISP Uganda, and I have had the opportunity to also see some of the work that Flavia is doing. But specifically on what Kofi has raised, there is a very fine line in making sure that clinicians, midwives, providers do their work of providing care, but also participate in digital health initiatives. And maybe just one point on what Kofi has raised is what we found is that make the technology as simple and easy as possible. One of those I saw Flavia mentioned is the SMS function, for example, that instead of making midwives sit down with a laptop to punch in figures, they could type a simple message on a feature phone, because in most cases you won't even find smartphones in the facility. But they have feature phones. So how do you help them do their work without also having to learn some of the new things on smartphones, for example, how to use Android features and so on? So we found that the role of the technology that you provide helps to alleviate that problem in terms of efficiency. If I can type a simple text, A.5 space B.6 space, and then send that message, which is coded but meaningful, then that saves time, but also helps me to communicate what I want to communicate. I thought I wanted to add that. Thank you.
Thank you.
Is muted or not? Okay. Or is this better? Maybe show the PPT. So maybe download.
This way or
The thing is that is not shown the whole. Yep.
and we'll know how to get the PDF to be a nice presentation.
So maybe you can download.
Yeah, if I download.
And full screen. Technology works. Okay, I'm Carlos Tejo from Solid Lines Company, and today I want to talk about our research that we are doing with the University of Oslo HISP Centre in order to know it is possible to use AI in order to improve the data entry in the DHIS2. Maybe it will be useful for the double data entry. Maybe just take a photo and upload it to the DHIS2 directly. So let's talk a little about the DHIS2. Most of you already know that is a widely open source solution for managed health data. And in the DHIS2, we are collecting information about programs, health programs. Sometimes you need to do this double data entry due to the law of the countries, because it's mandatory to use registries in paper. Also, you have a lot of registry books, or even for community health workers that go to the villages and take notes, and after that they need to put that back in the DHIS2 in another format. What is happening that manual entry is time consuming, resource intensive. You need people, you need time, and it's led you to also to have some errors, because in the paper they're going to say you this value cannot be between this and that, but it's also possible in the DHIS2. So what about generative AI? Okay, it's the fancy word now. Everybody is talking about AI, but in that part, AI, one part is generative AI. That is how to generate information from a source. Okay, and the source could be images, could be text, could be audio, and the output could be another image, text, a structure, unstructured, a JSON file. So with and for that we are using LLMs, large language models. What is the model that is used by the AI? What we can do, well, I have already said, but speech to text, you share an audio, and this is transcript. So you obtain the text. You can also obtain information from an image that contains text, and you can process it. And also from that text, you can generate JSON files. That's the approach that we are doing. So what is the problem? So the problem is the high workload of data transcriptions for analog to digital. So it takes time. There is a human limitation. If we want to move from paper-based to a digital, you need the time and you need the people, and sometimes you need to take decisions, but the data is not already in the system. So you not can take that decisions because the data is not there. using the tools. So our hypothesis, and I'm going to read it. Can Gen AI streamline data entry in DHIS2 by transforming images of paper forms and audio recordings into digital forms? So we're proposing a workflow. We're not proposing a final app, a final implementation, just is a technological approach. So the input could be images or audio, voice notes, a photo of a registry book, a photo of a form of a person that is reporting a case of malaria, a photo of an email of a reported case. From that, we process the information. It's a kind of pre-processing in the case of the audio in order to move from audio to text. And after that, also using Gen AI, with some extraction that is called the prompt in the AI field. With the prompt, we are going to move or to process the test and generate a JSON file that will be sent to the DHIS2. Yeah, and that's important. As software is not perfect, and the part of the human validation is still needed. Okay, things are going really fast, and things are going really good with the models, but still the human validation is needed. So this is an example of the steps that at the beginning we have the form. There is an image of a phone, of a form that is handwriting. We took a photo and we send it to we just develop an app, but it's just, now it's an app and in the future could be something different, but it's a web app. So we upload it to the app, and the LLM is a process that obtains the information, read the different fields, and generate and fill this form that is digital. And after that, you can change it in case there is a problem, because imagine that the data stat of symptoms, the LLM, the model is not reading properly, and you can change it here. And after that, the payload is generated and sent directly to the DHIS2. So what we have done, we are trying to test different use cases, from single data, single entry forms, to logbooks, registry books with more than one line. Photo of emails of reported cases, and audio in different languages. We have tested with English, French, Spanish, Swahili, Norwegian, with Arabic, and we'd like to test it all in other languages. We are not, so the LLM, the Whisper, is doing that work. It's not. We are trying to test different models, taking into account the difference between open source models and proprietary models, and to know which perform better than the other, and also test different instructions, different prompts, because depending on the use case, tweaking the prompt could leverage or improve the accuracy of the final data. So we have done this already, and there are some initial conclusions about the models. Open source versus not open source. Is there a winner? At this point, we can say no. Both of them performs quite good. Depends on the model, always. But we cannot say proprietary works better than open source. We cannot say that. We need to take into account the cost. And right now, the cost of processing images is higher than processing a voice. So in case of a future implementation, you need to take this into account. As I say, changing the prompt could improve the accuracy of the final result. For instance, dates, for instance, names of people or places. If you say, okay, extract this information, but take into account that we are talking about this country. So probably there will be some difference in the output. Yeah, and the human validation is still needed because you can read it, but sometimes you see the form. That form is like quite good to take the photo, but there will be some difference, a lot of difference if the photo is not so good, or if the logbook is the photo is moved, or there is a lot of change in the work in the workbook. So images, yeah. The quality of the accuracy of the final results really depends on the quality of the photo. The quality of the photo and the quality of what is written. But in that case, you are going to work with the photo. So you need to take that into account. In the case of free test, like names, addresses, like if the final results could contain typos if the image is not good. It's not going to be the same in the case of Boolean values, true, false, yes, no, or in the case of option sets in the DHIS2, you have a subset of valid values that you can say in the prompt, okay, and the value for that field must be this or that. Yeah, and the dates could be changing because in one implementation the year could be month and day, and another implementation is day and month. But with the prompt, you can say that. So take that into account. What about the audios? As far as we are doing, we see that normally it's easier to use the audios than the images. We are very surprised how good the LLMs are working with the audios. We have tested in Spanish, English, Swahili, and it performs really good. We're surprised about that. And even with long audios, that with other information that is not relevant for the final form. So what are the next steps in the collaboration between SolidLines and UIO HISP Centre? So we will try to test with more audios and more forms and different forms. We want to analyze the results, quantitative and qualitative. Quantitative, the accuracy. I want to see the accuracy of the models. And the models that we are using right now will not be the same models that we are going to use in 1 month, because this is changing a lot and really fast. We want to also to measure what is the quality of the human data entry versus the quality of the data entry if we introduce that part. So a human can be assisted by GenAI in order to introduce the data. Yeah, and maybe the most important part is, are these potential addition going to reduce the amount of time that people is taking to introduce data? In the part of quality, we want to see what is the reaction of the staff that is going to or could use that approach or that tool, and evaluate how is the human in the loop approaches. Important disclaimer. Okay, that looks really fancy. It's going to work. No. This could be a partial solution. The human factor is still needed. They need to be reviewed by a human. there could be accuracy issues if there is a lot of noise in the voice notes or a lot of issues with the handwriting. We need to take into account privacy and data security. Are we going to send this sensitive information outside our organization, even when it's going to reduce the amount of time? Okay, and that's why we are prioritizing in the comparisons the open source models. We have already tested some open source model that we can host in our machines, so data is not sent outside. Okay, and okay, two final things that are the bias of the model. Model has biases, and we need to take that into account. So that's why we shouldn't rely in only one model, and we need to test different models. And prompting the instructions are really, really useful in order to improve the accuracy. And we need to take that into account since the beginning. And each use case is different than the other. So if you want to see that or want to know more, today we're going to have two other opportunities. After the lunch in Auditorium 5, we're going to present this, but more with the demos part, live demos. And at the end of the day, in the poster session, at the same time than the journal session, we'll have a poster when you can try it yourself. So you can go there, and we have prepared some forms, and you can type and voice notes, and yeah, you can try it. And I think that's all from my side. Thank you very much.
Thank you so much. Thank you so much, Carlos. This is really illustrative of action research, because you embedded in the action and trying to solving the problem, and then while doing research. And I love the approach, which is mixed, qualitative and quantitative. I was a bit confused with the title when you say digitizing DHIS2 data. DHIS2 data is already digitalized. So I'm like, I'm not a native English speaker, but I don't think you can digitalize DHIS2 data. Maybe we could change or consider changing the title and saying, as one in one of your slides, Gen AI assisted data entry, which better capture the idea of the whole presentation. Your hypothesis looks more like a research question than a hypothesis, because it's very well framed, but my sense is that it's rather the research question than the hypothesis. I'm curious about how you measure the accuracy of the data that is entered. You pointed out at the end, because we as medical doctor, we have very good handwriting. It's very nice. I have a friend that says that it's like if we were trained in writing poorly during our medical courses. So how do you measure the accuracy of this? I would be very happy to hear more about it. Thanks.
Okay, so in order to measure the accuracy, we can try to measure different things. One thing is the model. In mind, you have the same form, handwriting by a doctor, and we use different models to obtain the final solution. maybe with one model perform better than the others. Maybe one model is capturing better the name or the address than the others. So that's why we can measure the accuracy of the different models. Okay. So this is the part of accuracy. And sometimes we are like quite surprised that even poor handwriting can be read by the models and obtain a final solution. Yeah, but we are like that part of accuracy between the models, and also another thing that can be measured is a person that is the person that is not entering the data in is not handwriting is the one that needs to type to do data entry. It's different person. So okay, I think that person here means a street number or whatever, and we can see okay, this is the what we have expected. This is what that the person entered. This is what the AI interprets. So we can measure also the accuracy between what is expected, what was done by the person, and what was done by the model.
Yeah, thank you very much for this presentation. I just have two questions, maybe clarifications. For your use case, you seem to be using a formatted kind of form. Was this also tested on where you have this free text on doctors' dots, and we are particularly looking for particular, words or phrases or keywords out of that text? And then the second one is about storage issues that you're going to run into in terms of the high quality picture that you are looking for. Could this also be looking at where I scan and transcribe as I go, rather than just keeping the pictures? Because I'm looking at the study where you're going to be having a lot of data stored in these books, and keeping those high quality pictures, I don't think you'll have space for that. We've had some failures in the scan forms about the storage. It requires a lot of resources. Thank you.
Okay, so starting for the last one, at least we are not in the approach that we are right now. We are not storing the data in the images in DHIS2, just in case. We have it in our phone and you can delete it. You need to take that into account in case that is a problem. And about the first question about other, I saw the easy single entry form one person. In the next presentation, we are going to show a logbook with different entries, and it looks like it works. Okay, so multiple entries. A register book with 5, 10, 2 entries is working, and with different qualities of the image. And at the end is an image, so could be a photo, an scan image that you scan the form and pass it. Yeah, it could be also something different, like a test that is copy paste from an email. Could be something different. Yeah.
Yeah, I think the solution is quite interesting. So I think the questions are just to kind of, so mine is some of the registers are as big as that table right in front of you. You've seen the longitudinal registers. Scanning them is quite something else. But that's not because you already made a disclaimer for it. My question is, taking an image of an image and having that image read by AI and then transcribed. Say, for example, you have a scan that is part of a mother's file, a pregnant mother with a scan, and that scan is part of the file, and you have to scan that note with the image in it. Does the model translate the image within the scan as well?
I don't know. We need to test it. I need to test it. We haven't tested with just, we have just tested with data with test at this point. But for instance, and we'll see that in the other presentation, we have tested with images of an email. So instead of copy paste the email, just take a photo of the email and send it to the model. But it's test. It's test.
This on. A quick comment and then a question. So I'm always struck with this whole, emergence of AI literature, which sort of suggests that we're going to compare it to the humans, right? And then, or we're going to compare it to perfect and then see how many errors are in it, where we kind of ignore the fact that humans make an enormous amount of mistakes. And so in many ways, the really interesting question is, does it do better than humans? Not how does it do better than perfect, right? Like we kind of almost hold AI to a higher bar than we hold humans. And so I was a bit intrigued by the way in which this research is being set up. You're asking, how do we take human generated data and put it into the system with the handwriting, right? Where we've already kind of allowed the errors to come in and then say, can AI fix them? Versus a kind of more interesting question is, how do we use AI to overcome the human errors to begin with? And so I'm wondering, is there any scope for thinking about that kind of a question?
No, thank you very much. And I think that somehow we are working on that, but it's interesting to also okay, GenAI is capturing the data, but if there is a mistake, can this mistake be fixed by AI? At some point, we are doing that with prompts, with the instruction. You can say, and the values for this field could be, imagine a malaria case, could be PF, PV, and mixed. And the person just say mix or something different, they can interpret that and change to the value that is expected. Things like that. But I think that is also something to consider and to add into the loop, into the process. Yeah, thank you very much.
Hi. My question maybe is a little bit similar, but I was wondering, it's more about, have you considered machine learning in this kind of process more formally in terms of improving models, not just kind of testing models against each other, but using that as a mechanism to train on the data that's coming in and improve it as in the environment where it's being applied?
No, we have not thought about that. This is just for the data entry, but maybe useful also to have like an extra step for the machine learning part. Yeah.
Just one question about the audio, because you talked about the forms and everything, but audio, what do you mean? What audio you're using? Because in our case, we mostly remove the register and forms in Bangladesh, long implementation. So now what we have the problem with the registration, because there's a name and everything you have to write. So we tried with the audio to make into text to audio, but it's not successful. So what you do with the audio, so if it will be very helpful.
Yeah, with the audio, with the test that we are doing is like people saying, okay, we want to report a malaria case of a person that is called blah, 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 blah. I think that is 40 years old, and the first symptoms happens a couple of days ago. And that part is transcript into test, and that test is transformed into JSON using the prompt. So the part of transcript from the voice to test is doing by the LLM, and what LLM in that case is Whisper, and it also depends on the quality of or the level of the LLM that can transcribe better or worse.
Thanks, Carlos. I think we have to end there. If I don't understand, none of you will come back for the next session after lunch. Some of you may also go to this session if you have more questions. And during the posted session, you have time for both our expert lounge and trying it in this posted session. So thanks to Flavia and Carlos and everyone.